ये वाला था ना। अच्छा वो फिर तो मैं मिनिमाइज करता हूँ ना वो उसको दे देता हूँ।
Assalamualaikum. Assalamualaikum. Can everybody hear me?
Yes, ma'am.
Yes. Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Okay. So today I'm going to start another component of your exam and of your medical microbiology course, and that is parasitology. Initially, as I posted in your group, I was going to start with immunology, but because of this course all going online, I've decided to start with parasitology because it's easier, and you just need, if you are going to study one parasite each day, you just need about an hour of it, and you can just learn it and just leave it till the end of the session when you have your sent-up exam. So if you go on studying this side by side as we take the lectures, then it is not going to be a problem for you to learn this topic. Immunology is a concept building topic, so I thought that when we come back on campus, I will start with those lectures at that time. Sounds good to everybody?
Yes, ma'am.
Yes.
Okay, so what is parasitology? Basically, it's the study of parasites, and as you know, parasites are one type of a microorganism which is available around us. And when we study them, it is referred to as parasitology. And what's a parasite? It's basically an organism that is going to obtain food and shelter from another organism, and it derives all benefits from this association. So when we are talking about parasites which are feeding or on our body, which are living inside our system and feeding on our body, then we are considering it as a pathogenic organism. And you can find numerous examples of parasites in the ecosystem, in the environment, where one organism is feeding onto another and surviving. For example, the insects, they are being taken up by the larger animals, and the smaller animals are being eaten up by the larger animals. So all of this is a form of parasitism. Whenever there is a parasite, a host is needed. A host is going to be the organism that is going to harbor the parasite. And when the parasite is going to multiply in that host, they are going to cause a lot of damage and destruction to the tissues of the host as well. So in case of the human parasitology, when we talk about human parasitology, we are talking about the parasite, which is a pathogen, and the host in this case is going to be the humans. Certain terms you need to know, and at the end I will post these definitions onto the group. So just understand the concept of the terms I'm going to use, because they are going to come, you are going to come across them in your curriculum often. Commensalism, you've heard this term before as well when we're talking about the bacteria. And we mentioned that commensals are those which are living on our body, and they are not providing any benefit to us, but they're also not providing us any harm. So commensalism is association between species with no benefit nor harm to either partner. It's just a relationship in which the organism and the host, they are in a sort of equilibrium with each other. Symbiosis is an association when both the species are benefiting and the survival of one is necessary for the survival of the other. Whereas parasitism is then an association in which only one partner is benefiting, and that is the parasite. The host may be affected, and in that case, the host may have two types of problems. Number one, they can be an infection or they can be an infestation. Can anybody give me the difference between infection and infestation? Shami, can you tell me the difference between infection and infestation?
Infection is caused by bacteria, basically, and infestation is something that is caused by, for example, ticks, for example, lice, something that is caused by bigger organisms.
Okay, but you are right about the infestation, that it is caused by ticks and lice. That means the ticks and lice are where in our body? In the inner side of the body or the outer side?
They live on the surface of the body. For example,
Okay, that is correct. Yes. Infestation is whenever the pathogen is on the exterior. And when we are talking, and this is basically when we are talking about parasites, we use the term of infestation. When we are talking about bacteria, it is always an infection, because the bacteria remain on the surface and they can go into the, they generally have a interaction with the inner tissues or deeper tissues to produce an infection. On the other hand, parasites, they can remain on the surface and produce a disease, and this is known as infestation. Whenever the organism is within the body, it is an infection. Whenever it is on the surface, it is an infestation. So when we have a parasitism, then there is an association between the parasite and the host. If the parasite is on the surface, it is referred to as an infestation. If it is deeper in the tissues or inside the body, then it is referred to as an infection. Different types of parasites: and endoparasite that live inside the body, ectoparasite that lives on the outside of the body. Very easy terms. Then you already know the difference between a pathogenic and organism and a commensal. Pathogenic are going to cause harm. Commensals, they are going to benefit from the host without causing any harm. Obligate versus facultative. Again, if we recall what we talked about in bacteria, obligate, they're strict. When we talk about obligate aerobes, we're talking about strict aerobes. When we are talking about parasites, when we say it is an obligate parasite, it means that it can only survive in a host. It cannot live outside that host. So facultative will be when both it can live in a host as well as it can live in a free form. Normally, it is not parasitic, but when it goes to the host, then it becomes parasitic in nature. So it is more of an opportunistic pathogen. Then we have an accidental host. Accidental parasite or the accidental host is when the organism is going to when the parasite is going to attach to a host which is not its normal host, then it is referred to as an accidental parasite. For example, if the host is a cat or a dog for that particular parasite, and then if it gets entry into the human beings, then it's not going to cause any disease in that individual. Rather, it will just pass out in the feces if it has been taken through the oral route, and this is then referred to as an accidental parasite. Then permanent parasites are those which have their adult lives in or on the host, whereas temporary parasites will be there for a short time period and then they will go on to the next host. The types of host, two types, definitive host and an intermediate host. And a definitive host is one in which the parasite is going to have its adult and the sexual stages of its life cycle. Whereas in an intermediate host, it has the larval forms and the asexual stages of the life cycle of the parasite. Then the intermediate host can actively take part in the life cycle, or the intermediate host can just be a place where the larval stage is going to stay and it is going to grow, and then it is going to pass down. Paratenic or the transport host is one which is going to harbor the larval stage of the parasite, and it is going to survive in that animal or in that host, and then it is going to move further. It is going to move to the second host where it is going to develop further. In case of the paratenic or the transport host, it is just acting as a vehicle of transport from one organism to another. There is no developmental cycle taking place or developmental stage taking place of the parasite in that host. Reservoir host, on the other hand, is an animal that can harbor the parasite for the whole of the parasite's life, and it is going to be the additional source of transmission of the disease in the community. Because the organism is, the reservoir host is going to be a sort of a carrier for the parasite, and it is going to remain in that host for the time period which is going to allow that parasite to be transmitted into the community, and therefore it is going to be a common and a persistent source of infection for humans. Vector is an organism, basically most of the time it's an insect, and this is responsible for transmitting the parasitic infection. And a classical example of this is the fly. The fly acts as a vector for the transmission of a number of diseases, including a very common disease which you've heard about, that is amoebiasis. Amoebiasis is a condition which is caused by a parasite which is known as Amoeba histolytica, and we are going to study it in just a few minutes. And this is basically the parasite forms are going to be passed out into the fecal matter. Now, if the fly sits on that fecal matter, which is contaminated with the Amoeba histolytica, the fecal matter along with the parasite can stick to its legs, they can stick to its wings, and whenever this fly is going to sit on any food particle, it is going to transmit that parasite onto the food, and that food becomes contaminated with the parasitic infection. Whosoever is going to eat that contaminated food can develop amoebiasis. So vector is an organism. Vector is a vehicle which is going to transmit the parasite from one side to the other without having any involvement in the development of that parasite, or without that parasite going into the body of that organism. So it's just sticking to the surface and it is being transported from one place to the other. Is this concept clear?
Yes, ma'am.
Yes, ma'am.
These are few definitions which are generally asked by the examiner when he starts with your parasitology biology. Biological vectors are those like I just talked about a mosquito, about a biting insect, and in some of these vectors you will find that the life cycle is also going to be carried out. For example, the biological vector of the Plasmodium, which is the causative agent of malaria, is a mosquito. So when we talk about vectors and their types, we are talking about two types of vectors: mechanical vectors, the example for which I've already given, that is the fly, which transports the cyst and of the amoeba from one place to the other. And then there are the biological vectors, which are going to allow the parasite to get into their body, develop a few stages of their life cycle in their body, and then they are going to transmit that form of the parasite, which is going to infect humans through the bite or through the feces, which then gets enters the skin of the humans through the rubbing or through a minor abrasion on the surface of the skin. The examples of these you will come to know as we go on studying this topic. So when we talk about parasitology, we are talking about two branches. Number one is protozoology, and number two is helminthology. Protozoology deals with the protozoa, whereas the helminthology is further subdivided into platyhelminthes and nemathelminthes. Platyhelminthes are the flatworms, and the nemathelminthes are the roundworms. So, difference between protozoa and helminths is that protozoa, they're going to be unicellular, and all the functions of the organism is going to be performed by that single cell. Whereas in case of helminths, they are multicellular organisms, they are more advanced, they are more specialized. Each cell has a special function to perform, and they are more of an animal sort of a parasite. Protozoa further subdivided into four groups: amoeba, flagellates, sporozoa, and the ciliates. Flagellates are further subdivided into hemoflagellates and intestinal flagellates. These are the classifications you are sometimes asked in the SEQ exams. Helminths have three groups: trematodes, nematodes, and cestodes. A common viva question which I have commonly asked the students, a very easy question: could you name me the three groups of helminths? And believe me, students don't even remember these three names, and parasitology shall have to pertain. But anyways, you need to remember that helminthology is subdivided into three groups, that is the trematodes, nematodes, and the cestodes. Whenever we talk about the any parasitic infection, we are talking about four important things. Number one is the source of infection. The source of infection could be different ways. It could be an infected man, it could be an animal, and an arthropod. An infection could be through the contaminated food or water. It could be through the soil, contaminated soil. It could be through the inhalation of dust containing the particles of that parasitic infection. Number two is the portal of entry. So the portal of entry could be the ingestion. It could be the inoculation. The organism gets inoculated into the skin, like the bite of a mosquito is going to transfer the malarial parasite into the skin. Inhalation. Certain parasites, they are found in the dry form in the dust, and they can be inhaled. And the cycle can start from the congenital. The mother can pass certain parasitic infections to the newborn in utero. Then there is the venereal contact that can also result in certain infections, and then there are the biting insects. Once the organism is inside the body, then the disease production occurs in the host. But for the continuation of the life cycle of that parasite, a portal of exit is very necessary. So after producing the disease in the host, it has to move forward, it has to move on. First, it is going to go into the environment, and from the environment, it is going to enter a second host. And this is then going to continue the life cycle of that parasite and the persistence of the parasitic infection in the community. So the portal of exit, like the portal of entry, could be numerous. It could be the respiratory tract, it could be the GIT or the genital tract. And again, it can be taken up by a biting insect. The blood can be sucked up by the insect and then transmitted to another individual. Again, the example would be of the malarial parasite. What are the effects of the parasite on the host? Different types of effects are produced. For example, number one, they can compete with the nutrition which is present in the host, like vitamin B12. And if the parasite is taken up by the vitamin B12 from the host, it can result in megaloblastic anemia. Other tapeworms, they are going to be situated in the intestines. They are going to take up the nutrition, resulting in malnutrition of the host. And this is most commonly seen in small children. Then they can ingest the blood. When they are present in the intestines, they can hook up onto the intestinal epithelial cells, destroy those cells, and hatch onto the capillaries in the intestinal wall, and then they can suck up the blood, in some cases up to 250 ml per day, and this again results in an iron deficiency. Number two, they can destroy the tissues. They can destroy the tissues not only at the site of entry, but also inside the body, once they are establishing the infection. At the surface, some can cause the swimmer's itch, for example, those parasites which are present in the water, and if they contaminate the skin of the swimmer, they can cause the swimmer's itch, or they can cause a lesion at the site of attachment. Then intestinal worms which are present, they can cause lesions in the intestinal lumen through the damage to the intestinal epithelial cells. Third is the tissue change. They can cause serious consequences to the host. For example, certain parasites, they can cause hyperplasia, others can cause hypertrophy, metaplasia, and if the parasitic infection remains in the individual for a prolonged time without treatment, they can even result in metastatic changes and result in neoplasia. The classical example of that is a parasite which is known as Schistosoma hematobium, and this causes an infection of the urinary bladder, and ultimately, if this condition is not treated, it can result in urinary bladder carcinoma. This is a common viva question: which parasitic infection is associated with neoplasia? So Schistosoma hematobium is the parasitic organism which is associated with the bladder carcinoma. Then they also secrete certain toxins and enzymes. This can cause numerous pathogenic responses in the body, and they may inhibit the immune function as well. The presence of the parasites can also cause mechanical damage. How? Or mechanical obstruction. Elephantiasis, if you heard, it's a parasitic infection, a symptom produced by a parasitic infection, and this results from the blockage of the lymphatic system. Similarly, the tapeworms, they can also block the intestine. They can cause the ascaris or the roundworms. It's a common worm which is present in children. If it is present in large numbers, it can form a bolus, and this bolus can block the lumen of the intestine and cause the signs and symptoms of a disease. Then Plasmodium, which is the causative agent of malaria, it causes changes in the RBCs, as a result of which they become more sticky and they clump together. And when these clumps together RBCs, they go into the smaller vessels, capillaries, they can cause clogging of these capillaries, and the blood supply to the particular area that becomes blocked. Now, whenever we are talking about any parasitic infection, remember that you need to learn the parasite with the following things. You must know about its geographical distribution. You must know where it is found in the host, that is the habitat of the parasite. What are its morphological forms? I'm not asking you to remember their sizes. I'm not asking you to remember a little bit of details about the morphology, but you must know the forms which it exists in. For example, Antiamoeba has two forms. It has a cystic form and a trophozoite form. And you must also know which of these two forms is infective to the human host. Then the life cycle is very important, and the life cycle is the component of the pathogenesis of the parasitic infection. Then we need to know what is the source, what is the port of entry, the vector, the reservoir host, and the portal of exit for that parasitic infection. Pathogenicity and the clinical manifestations, any immunological manifestations, if they are produced by the parasite, and how do we diagnose this parasitic infection. Clear up to this point? Any questions? Any questions?
No, ma'am. No, ma'am.
No, ma'am.
So this was a brief introduction to the parasitology in the terms which we are going to be commonly using throughout the description of the various parasites. And now we start with the first parasite, and that is an organism which belongs to the protozoology group, and it is a protozoa, a very common organism which you heard about, and that is Antiamoeba histolytica, which is the causative agent of amoebiasis. And it produces dysentery. Can anybody tell me a bacteria which produces dysentery? Which bacteria produces dysentery?
Shigella.
Jejunum.
Yes. And what are the features of dysentery?
A bloody diarrhea,
Good. What else?
fever,
No.
dehydration,
Dehydration, fever, and with the diarrhea, what are you going to have in the stool specimen? Blood mixed with? Why does
mucus,
yes. Why does the blood come out? The blood comes out because the tissues are being destroyed. So along with the blood, the destructive tissue is also going to come out. So we will find blood and mucus, both of these things in a specimen of dysentery. Clear? So let's move on. And we are going to start with protozoology. And the first organism which we are going to study is from the intestinal protozoa, because the protozoa are intestinal as well as blood and tissue. So we are going to start with the intestinal protozoa, and amongst them we have the amoeba, and we are just going to concentrate on those organisms which are pathogenic and common to human infections. So amongst the amoeba, we have 5 or 6 different species, but the most important and the pathogenic one is the Antiamoeba histolytica. Amongst the flagellates, we have Giardia lamblia, which is the cause of giardiasis. Again, it's going to cause a abdominal discomfort and diarrhea. Then Coccidia, which is Cryptosporidium and Isosporabella, and Microsporidium. So we'll start with Antiamoeba histolytica. It's the causative agent of amoebiasis or amoebic dysentery, and it has a global distribution. All over the world, you'll find this sort of an infection, but it is going to be more common in the tropics and the subtropical region. And the most important thing about amoebiasis is that if it is left untreated, it can cause invasive disease. And once the invasion occurs, it can go either to the liver or to the lungs, which are the primary sites of filtering of these organisms, but it can go anywhere in the body and produce an abscess. And this amoebiasis is more common in children less than 5 years of age. When we talk about amoebiasis, we are talking about a condition which is going to be more prevalent in the underdeveloped countries because of the poor sanitation, because of overcrowding, because of the lack of hygiene. All of these factors, they are going to contribute to the spread of amoebiasis. In the industrialized countries, it's more in the institutions, it's more in the through the refugees or immigrants which are coming to that area. Those are the populations which are going to have a high incidence. It's transmitted through the fecal-oral route, and we have contaminated food or water, and it can also spread from person to person. This person to person spread is through the contaminated hands. Then we have the habitat, which is the mucus and the submucous layers of the large intestine. That is the place where it is going to go and settle down and produce a disease. Habitat will always be the site in the human body where it is going to settle down and it is going to produce some damage. The life cycle will start maybe from the mouth and it will end through the exit of the parasite in the fecal matter. But the habitat is not the GIT. It is going to be the specific part of the intestine where it is going to settle, where it is going to produce the damage. Remember that whenever you are trying to answer the question, what is the habitat of this particular parasite? Morphologically, two forms. Number one is the cyst, and number two is the trophozoite form. The cyst is going to be passed in the feces. It is more resistant for survival in the environment, and this is the infective form of the parasite. Whenever you are asked which is the infective form of Antibody, it is the cyst. And number two is the trophozoite, which is the active form, which is the feeding form, which is the motile form of the parasite. And this is also the form which replicates by binary fission, and it causes the increase in the number of the parasite within the human body. This is found most commonly in the host, because as soon as it is passed out into the fecal matter, it is a very fragile, delicate organism, so it's going to die off. Until and unless the stool contains the cyst, the infection will not be passed on. So when we have an Entamoeba histolytica infection, a host is going to pass out both the cyst and the trophozoites. Trophozoites will not be found in the stool because they will be destroyed as soon as they are passed out. The only thing which we can look for in these cases are the cysts, and they are going to be present in the fecal matter, and they will help in the diagnosis. Trophozoites are found in the intestine, and they go through the process of encystment to form a cyst, which is then passed out into the feces. And once the cyst is taken up with the contaminated food and water, it is then going to go down into the intestines, and once it is in the intestine, then it will go through the process of excistation and form a trophozoite. So these forms, they are changing from one to the other depending upon the habitat, depending upon the place where they are going to be present. So this is the trophozoite form. It is just like an amoeba. It has pseudopodia, by means of which it is mobile. It's the growing stage of the organism. It has a nucleus, an endoplasm, and ectoplasm. This is a picture which is stained, and this is unstained, and this you can see is the trophozoite forms. It does not have a particular shape. It has pseudopodia, by means of which it is going to move in the liquid matter, and it can go from one place to the other. The second morphological form is the cyst. It is a spherical body. They can be large cysts, they can be small cysts, they can be free cysts, and all of them, they have certain features in common. The mature cyst is going to have 4 nuclei, and it will have a thick wall around it. And this is the cyst which is going to be passed into the stool. And when we are looking for diagnostic criteria for the presence of Entamoeba histolytica in a specimen, we are looking for these cysts which have 4 of these nuclei, because the intestines, they will also harbor some Entamoeba species which are non-pathogenic. We differentiate them from the pathogenic by the number of these nuclei. And these are the immature cysts which have the chromidial bars and glycogen bars. And this glycogen mass is going to be utilized as the cyst is going to mature. Both the chromidial bars as well as the glycogen mass is going to be utilized for the production of a mature cyst, for the production of the wall around the cyst, and of these nuclei are going to divide into by binary fission into 4. So this is what we see in a unstained and a stained preparation of a stool specimen of a person who is passing Entamoeba histolytica cyst. So Once the organism is taken into the body, it is going to go into the large intestine, it is going to feed on the bacteria and the debris, and it is going to replicate by binary fission. The process of excistation occurs in this is the mature cyst, which is going to be taken up by the individual in contaminated food and water. The process of excistation and the conversion into a trophozoite form occurs in the small intestine. This occurs through the destruction of the there is a destruction of the cell wall. Then through that destruction, the trophozoite is going to, the amoeba is going to emerge. It is going to then undergo nuclear division, and then it is going to undergo division into 8 amoebola. And these are the trophozoites that are then going to migrate to the large intestine. And this is known as the conversion of the cyst into these 8 amoebae forms. This is known as excistation. Then is the process of excistation, which occurs when the trophozoite is going to round up and it is going to secrete a wall around it. And this is going to utilize the chromatin bars and the glycogen mass for conversion from a trophozoite into a mature cyst. And it is this cyst is able to survive for weeks to months. Now, coming to the life cycle of the parasite. What happens is that the cysts, they are going to be, let's start from here, the cysts are going to be passed out into the fecal matter. Each and every life cycle, you must know how to make a diagram of that life cycle. Practice it, and when you know the life cycle, you can write down the pathogenesis. You do not need to separately learn the pathogenesis. You just need to add a few points, and along with the life cycle, you will be able to attempt the question on the pathogenesis. So the cysts, they are going to be ingested along with the food and matter, and these cysts, they are resistant to the acidity of the stomach contents. So they are not going to be destroyed. The cyst wall is not going to be destroyed, although it becomes weaker. But as it travels down into the intestines, then it is going to, in the small intestine, the wall ruptures and the new amoeba, the tetranucleate amoeba, which has the 4 nucleate, that emerges. And now this is known as the metacystic amoeba, and this is then going to divide into, by binary fission, and produce 8 small trophozoites. These small trophozoites can remain within the lumen of the intestine, and once they remain in the lumen, they can then convert themselves into the precystic form, and the precystic form then undergoes incistation, forming a cyst which is then passed. So either they can directly grow and change into the cyst, or what they can do is then they can invade the epithelial tissue of the small intestine. If they invade the epithelial tissue of the small intestine, they are going to, the large intestine, they are going to cause damage to the epithelial cells. They will form ulcers, and these
Excuse me, ma'am.
Yes, beta.
मैम स्लाइड्स नहीं नजर आ रही है और आपकी आवाज थोड़ी सी अनक्लियर है.
Okay, beta. Now, can you see this clearly?
Yes, ma'am.
You can hear me?
Yes, ma'am.
Okay. So let's begin with again. You have these cysts which are going to be passed out into the fecal matter, and once they are ingested with the food or water, they are going to go into the small intestine, and the stomach contents, they are acidic, they have an effect on the cell wall, but they do not damage the cyst wall to a great extent. But as they pass down, the wall becomes weaker and the amoeba is going to come out, and this process is known as excistation. Then we have this metacystic amoeba, which is going to divide by binary fission and produce 8 small amoebae. This then grow and they can form the trophozoite forms, then the precystic form, and then the process of encystation can occur, and the cysts are then again passed out into the fecal. This is one part of the cycle. The other part is the invasive form of these trophozoites. These invasive forms, they are going to go into the, they are going to damage the cell wall of the large intestine, the epithelial cells of the large intestine. They will form ulcers. These ulcers may remain shallow on the surface or they can become deeper. And if they erode into the deeper tissues, they can also erode into the blood vessels. And if they go into the blood vessels, then they can be carried by the portal vein to distant sites of the body. And the first area which they target or which they reach is the liver. So an extra intestinal amoebiasis commonest site is the liver because that is the first area which the portal vein goes to. Then it can cause abscesses in the lungs. It can also cause abscesses in other parts of the body. But liver, lungs, and brain is a very rare site for the occurrence of Interneba histolytica abscess. So there are two cycles which the trophozoites can follow. Number one is the non-invasive form, and number two is the invasive form. Spread of the disease is through poor sanitation levels. A common source, food or water contaminated with the cyst, and that water is then being distributed to a community. When we have a water supplies contaminated with leakage of the sewage leaking, and then we have the human feces being utilized as a fertilizer. All of these can cause the contamination of food and water which we are consuming and cause the spread of the disease. The cysts, they can live up to 30 days outside the body. They are also resistant to weak chlorine, but if we need to get rid of them, then we need to use higher concentrations of chlorine, iodine, or we need filtration plants. And sexual transmission in homosexuals has also been said to be present, especially in the industrialized countries. Main source of infection in case of Interneba histolytica is the cyst passing asymptomatic carrier or a chronic patient. The patients who are acutely ill, they generally they are not a significant transmitters of the disease as they pass non-infective trophozoites. Any person who is acutely ill will be passing diarrheal stools, will be having severe dysentery. And in that dysenteric phase, he will be passing more of the trophozoites and very few of the cysts. So the trophozoites, as I've repeatedly told you, they do not survive in the environment. So they cannot be the primary source of infection in an individual who is ill or in an individual who has invasive amoebiasis. Because in both these situations, cysts are not being formed. The cysts either do not have the time to form as the patient is very acutely ill, or since the trophozoites have moved into the deeper tissues, they are no longer present in the intestine for the cyst to form. So in this case, you will not find any cysts in the stool matter, and these are not significant transmitters of the disease. Flies, cockroaches, they have also been implicated as vectors, as I was discussing with you when we were talking about vectors. The flies can sit, the cockroaches can be contaminated with the fecal matter, and once they contaminate the food, they can be a source of infection for the spread of the disease. On the basis of clinical assessment, we can classify amoebiasis into asymptomatic growth and the symptomatic growth. Asymptomatic, about 85 to 95% of the individuals have no symptoms and they generally recover because it's a mild infection. 5 to 15% will have asymptomatic infection because the colonization is heavy and the intestines have been colonized with or without tissue invasion. And 5% of the individuals will have an extra-intestinal invasive infection, and they are also going to present with symptoms. Invasive disease depends upon the pathogenicity, upon the dose of inoculum, the host factors, if the cell-mediated immunity is impaired, if the individual is on steroids, it is all going to affect the disease production. And the virulence of the infecting species, like the presence of surface adhesion factors, release of proteolytic enzymes, and release of cytotoxins by the Amoeba histolytica, they are all going to promote the production of invasive disease. Intestinal disease includes different types. Number one is the asymptomatic cyst passer, asymptomatic colitis only. There is no dysentery, amoebic dysentery. Then they can be amoebic appendicitis, they can be an amoeboma, a post-dysenteric colitis, or it can be a complication of any of the above. Extraintestinal disease, the commonest I told you is a liver abscess. Then they can go to the lungs producing a pulmonary or a pleural amoebiasis, cerebral, cutaneous, splenic, urogenital tract, any part of the blood supply reaches can become complicated with the abscess formation due to Amoeba histolytica. Pathogenesis includes the secretory enzymes and the enterotoxins or the cytotoxin. Both of them they cause direct tissue destruction. Number third is the pathogenic factor is the contact-dependent cytolysis. That is, through contact, it causes direct tissue, and this is because of the adherence of the trophozoite to the target cells, because of the pore-forming ability of the trophozoites, and because of the enzyme 5-phospholipase A, which is secreted by the amoeba, and it causes cytolysis. Basically, over here, I'll just show you a picture of the this is the intestinal lumen, and here you have the epithelial cells. When these trophozoites they come in contact with these epithelial cells, they are going to cause destruction of them through contact dependent killing. And once they are going to destroy these cells, then they will be an opening through which they can pass into the submucosal layer. Within the submucosal layer, the multiplication through binary fission is continuing, and also they are secreting various enzymes and proteases which are going to cause the destruction of the tissues in the submucosal layer. Any neutrophils which are going to come to that area, they are also going to be destroyed through the contact-dependent killing. And therefore, the organisms they are able to persist in this environment, and then as they multiply, they can penetrate into the deeper tissues, they can cause destruction of these tissues and go into the peritoneal cavity, causing an infection in that cavity, or they can be they can go through the capillaries, that is the portal vein, and they can go to the various organs in the body. So, in case of non-invasive, we have the amoeba colonizing the intestinal mucosa, and in case of invasive, we have the intestinal mucosa being invaded, or they can go to the extraintestinal sites. Now, the area which is most commonly involved in case of amoebiasis, in 85% of the cases is the cecum, and in 40% of the cases is the rectosigmoid colon. The lesions they are going to begin as small foci of necrosis, and they are going to progress to the formation of ulcers. So the lesions will be pinpoint in the earlier stages, and they will have a narrow neck, and they will have a larger bottom. And then they are going to progress to larger ulcers, which will have a wider opening at the top, and the bottom would be in the shape of a flask. So these are the initial lesions which you can see. They are small nodules. They will have these pinpoint openings, and you can just see a small nodule, and there is very little inflammation between these lesions. As the ulcers they are going to enlarge, they are going to retain the narrow opening, but the base is going to keep on spreading. And this is because the trophozoites they are causing destruction of the tissues, and as they move towards the lateral side, they are going to continue the destruction and causing the spread of the organism both towards the right and left and towards the bottom. Now, the muscle coat of the large intestine forms a barrier. So therefore, these are going to spread laterally instead of going deeper into the tissues. And this gives a picture of a flask-shaped ulcer. And these flask-shaped ulcers are pathognomonic for Amoeba histolytica amoebiasis. And this helps us to differentiate the amoebiasis from other conditions of the intestine, like the ulcerative colitis or Crohn's disease. This is basically a flower-shaped ulcer, and the trophozoites are going to be seen at the boundary of the growing ulcer, because over here at the margins, they are going to produce the proteolytic enzymes, which are going to cause the destruction of the tissues. And this destruction at these both ends, they are so this is I was talking about the margins of the ulcer. They are going to have the active trophozoite forms, which are going to cause the destruction and the spread of the ulcer into the towards the sites. So intestinal symptoms include mild to intense symptoms, which can be transient or they can be long-lasting, and the patient can present with diarrhea, cramps, flatulence, nausea, or this can be without dysentery, or it can be accompanied by blood and mucus in the stools. They can be abdominal pain, they can be tenesmus, and they can be an amoeba, which is the collection of these amoeboid organisms at a particular place, and this forms a palpable mass which causes obstruction in the intestinal lumen. These are the complications. Amoebic abscess in every part of the body, it can occur, and it can cause destruction of the, it can cause abscess formation in those areas. An example of cutaneous amoebiasis, over here you can see the various sites where these amoebiasis can occur on the surface of the skin. Then we have the liver. From the liver, the organisms, they can rupture into the adjacent areas, they can rupture through the diaphragm into the lungs, or they can be directly carried by the circulation to the lungs. Let's come to the diagnosis of intestinal amoebiasis. Intestinal amoebiasis, we are going to put them into two groups. Number one is the symptomatic group, which presents with acute amoebic dysentery, and the asymptomatic group, which presents with the very little symptoms or no symptoms, and these are the cyst parsers or the cyst carriers. So when we talk about the symptomatic group, we are talking about four diagnostic tools: stool examination, blood examination, serological tests, and the molecular diagnosis. In the stool examination, the most important thing is the stool examination in case of Amoeba histolytica, and we get a question on this very commonly. It has two components: macroscopic examination and the microscopic examination. In the microscopic examination, we look for the Amoeba, trophozoites, we look for the Amoeba, trophozoite or cystic forms, and as well as we look for certain general characteristics. When we get a stool sample which is suspected of amoebic dysentery, we ask for the history and we look at the specimen, and we see that the patient complains of passing 6 to 8 stools per day, copious in amount, with an offensive odor, dark red in color, and the stool specimen is mixed with the blood and mucus. The reaction of the specimen is acidic, and it is not adherent to the container in which the specimen is collected. Microscopically, you see that the cells are scanty. There are few pycnotic bodies, few pus cells. There will be macrophages, epithelial cells, RBCs, and Charcot-Leyden crystals. These are diamond-shaped crystals, and they are said to be pathognomonic of amoebiasis. This is a picture of Charcot-Leyden crystals. So, then number two important thing which we need to see is in the microscopic examination is the presence of trophozoites. The trophozoites or the cysts can be seen either through a unstained preparation, or we can use various stained preparations. Blood examination, leukocytosis. Serological diagnosis is negative in the early stages of the invasive disease as well as in the non-invasive forms. So if the patient does not have any invasive disease, then the serological diagnosis will be negative. And in the early stages of invasive disease, also this would be negative. This diagnosis depends upon either the antibody detection test or the antigen detection test. The antibody detection tests include number one, the indirect heme agglutination test, enzyme immunoassay or ELISA, and immunodiffusion. You just need to remember the names of these tests and nothing else. Then the detection of the antigen. The antigen is present on the parasitic body, so we are going to look for the antigen on the presence of the on the surface of the parasite with the help of monoclonal antibodies. And if these antibodies react in a stool specimen and give us the positive reaction, then it indicates that the parasite is present. And this will also help us in differentiation between the pathogenic and non-pathogenic species in the stool. Molecular diagnosis is through PCR and especially important for if you want to differentiate between the species. And it is also very important because it can detect one trophozoite per sample. But since it is an expensive procedure, it is only utilized in those situations when we have run out of options. Clinical diagnosis can be helpful through colonoscopy or sigmoidoscopy because we can take the sample from the ulcer base and we can send a biopsy, and this will show the presence of the trophozoites and it will help us in differentiating between amoebiasis from ulcerative colitis. The carriers or the asymptomatic group, again, we will carry out the stool examination, the blood examination, and the serological test. And over here, the stool examination can show the presence of the cyst. And the culture of the stool or the animal inoculation, they are mostly for research purposes. Blood examination does not show any specific positivity or any specific result. And the serological diagnosis would be negative if there is no tissue invasion, but if there is a tissue invasion and it has been present for a long time, the patient will be positive in 70% of the cases. This is the difference between the amoebic and the bacillary dysentery. And you can see that during the bacillary dysentery, the patient complains of more copious diarrhea. The amount may be small, but the number of stools being passed are more than 10. In case of amoebic, it has an offensive odor, whereas bacillary has an odorless stool specimen. It's bright red because fresh blood is being passed out. It contains blood and mucus, and the reaction is alkaline. Microscopically, there will be differences like the pustules will be useless in case of bacillary. The RBCs are going to be in the form of rouleau formation. Macrophages will be present in a large number, and the ghost cells which do not have any nuclei, they will be present in a large number. Bacteria would be present in few, but the parasites would not be seen. Just I'll take one or two slides for amoebic liver abscess, which is the commonest complication of the intestinal amoebiasis, and the metastasis via the bloodstream. It goes primarily to the liver through the portal vein, and the lesion starts as a small size lesion, but as it grows, it can produce and involve the entire lung lobe. The most important thing about amoebic liver abscess is the presence of a pus, which is chocolate colored. And this chocolate colored pus is made up of necrotic material. It does not have any bacteria. It does not have any trophozoites in the center, but towards the margins, if you take a biopsy of the margins of the abscess, you will find the trophozoites, but this pus itself does not contain any trophozoites or any bacteria. It just is made up of necrotic material, and it is chocolate colored, and it is known as the anchovy sauce pus because of its consistency and because of its color. The same pathogenesis as in case of the amoebic abscess in the intestines, the ingestion, excistation, production of the trophozoites, multiplication, then tissue invasion, producing flower-shaped ulcers, which can go via the bloodstream to the circulation, resulting in amoebic liver abscess. With this complications, it can result in hepatocoma, hepatorenal syndrome, It can spread to the brain, kidneys, or the lungs, or it can occur, or secondary bacterial infections can occur, especially when this abscess is being drained or we are carrying out surgical procedure for the removal of the abscess. And in some situations, the abscess may rupture spontaneously towards the exterior, and that can also become infected. When we want to diagnose an immediate liver abscess, we go for the clinical diagnosis, which shows the upper quadrant pain. The patient will have fever and a history of dysentery. On blood examination, there will be leukocytosis and the ESR would be raised. Liver function test would be generally normal. And we will see the cyst in the stool examination in only 10 to 15% of the cases. Radiological findings are the commonest diagnostic feature for immediate liver abscess, and the common sign is the elevation of the right dome of the diaphragm or the tenting of the diaphragm. And this is positive in 75% of the cases. So this, if you can see, is it has lost its curvature. Arrow has gone. It has lost its curvature on the right side. And liver biopsy and the serodiagnosis. And serodiagnosis is going to be positive in 90% of the cases of extraintestinal endometriosis. And we have this all back to you. Need to just remember the names and you can put them wherever a serodiagnosis is required in case of parasitology. Any questions? Any questions? Any portion of the presentation which you need to be, you can send me a message and I will post it to the group. No questions?
No, ma'am.
Okay, anything which you need to know further, please post in the group and I'll answer over there or I'll post a picture over there. Thank you.
ये मैं लगा दूं। ये मैंने इसीलिए उतारा।